Hey guys, welcome back to my channel, The ENT Resident. In my previous class, I talked about the different types of labyrinthitis. The one type that I didn't discuss is the circumscribed labyrinthitis, or also known as labyrinthine fistula. So today our topic of discussion is labyrinthine fistula. You can also now purchase my notes. I've added links in the description. Okay, so let's get started. Now, what is labyrinthine fistula? Labyrinthine fistula is an abnormal communication between the inner ear or the labyrinth and the middle ear. And most commonly, it results from erosion of the bony labyrinth, especially by cholesteatoma. So, what we see here is there is a loss of enchondral bone without any loss of perilymph. So, a part of the bony labyrinth gets inflamed and this whole case involves only the bony labyrinth, and there is no involvement of the membranous labyrinth. The other name for labyrinthine fistula is circumscribed labyrinthitis. And a very important viva question and even a PG entrance NEET PG question is, what is the most common site of labyrinthine fistula formation? And that is the horizontal semicircular canal, or also known as the lateral semicircular canal. Next, let's talk about what are the different causes of labyrinthine fistula. So obviously the most common cause over here is a case of CSOM with cholesteatoma. Other rarer causes are neoplasms of middle ear like a carcinoma or glomus tumor, or there could be a surgical or accidental trauma to the labyrinth. Now, how will a patient with labyrinthine fistula present to you? Now, most of the times, the patient can remain asymptomatic, or if the patient is presenting with symptoms, the typical symptom is usually brief periods of imbalance, disequilibrium, or vertigo. However, it is more important to remember that this is not the case all the time. The patient usually has normal equilibrium most of the time. There'll only be brief periods of disequilibrium or vertigo. And a very, very important clinical test that we perform is the fistula test. We'll see that the fistula test is positive. So, what we see here is basically there is an abnormal communication that forms between the labyrinth and the middle ear. Now, there's a damage to the bony labyrinth, as a result of which the part of the membranous labyrinth gets exposed. Now, the membranous labyrinth that gets exposed is now sensitive to any pressure changes that might happen over here. So, whenever you apply positive pressure to the external auditory canal, we'll see that there is a formation of that the patient will complain of vertigo and nystagmus towards the affected ear. Now, this positive pressure can be applied either by alternating pressure on the tragus, or you can even use a Siegel's speculum. So that is how you perform the fistula test. Now, we see that on applying positive pressure, the patient develops vertigo and nystagmus towards the affected ear. And when there is negative pressure applied, it would induce vertigo and nystagmus, but here the quick component will be directed towards the healthy side. And this happens because of amphilofugal displacement of the cupula. Now, the nystagmus that we see, what are the different types of nystagmus that you can see here? Or rather, the more position of the nystagmus, direction of the nystagmus. Now, if there is a fistula of the horizontal semicircular canal, the nystagmus will be horizontal. If there is a fistula of the posterior semicircular canal, the nystagmus will be vertical. If both the semicircular canals are involved, in that case, the nystagmus will be rotatory in nature. And another phenomena that we see in a case of labyrinthine fistula is known as Tullio's phenomena. Here, what we see is on hearing loud sound, the patient will have a period of brief imbalance. That is known as Tullio's phenomena. So, these are all the clinical features that you will be seeing in a case of labyrinthine fistula. Now, let's move on to how will we investigate the case. So, first of all, diagnosis is very easy over here. It is a clinical diagnosis which can be confirmed by performing the fistula test. Second, we can perform a HRCT of the temporal bone, which is best for detecting the bony erosion of the semicircular canals. And last, MRI is usually not needed, but we perform an MRI only if we are suspecting any complications, say any intracranial complications. In that case, we'll be performing a MRI as well. Lastly, how do we treat the case? So, first of all, we have to perform a surgery where we have to completely remove the cholesteatoma matrix from the fistula side, and we perform a mastoid exploration and removed any disease inside. Second, we have to give systemic antibiotics before and after the surgery so as to prevent any spread of infection to the labyrinth. So, this is all about labyrinthine fistula. If you have any questions about this, please note them down in the comment section and I'll get back to you.